Hi, good afternoon, everyone, and welcome to this talk event by Sanjeevani. Today is the 13th of June, and we have our esteemed guest, Dr. Neelam Aggarwal. Welcome, Dr. Aggarwal, to Sanjeevani and this talk event. Uh, Over the past few months, we have presented information about memory changes, dementia, Alzheimer's, people who are caring for uh, patients going through this concern. There had been lots of questions from the community. And today we have the expert on this subject to present. And if you have any questions, please feel free to ask, and the questions will be addressed at the end of it. The recording for this presentation will also be available on our website if anyone you want needs to be shared. So I'm going to present it over to Dr. Aggarwal. Welcome, Dr. Aggarwal. Session is
Thanks,
yours.
Pramila. Thanks, Pramila. And I'm delighted to be here today to really just start the discussion um, about, cognitive and memory changes and also how that can relate to mental health issues. Um, Before we went live today, Pramila and I were noting that here in Chicago land, we've opened up for post-COVID, if you will. And, downtown, it is very busy right now. People are moving around, trying to get back out to get some sense of normalcy back in their lives from what happened last year to all of us. And we were all affected by this. And members of our community, of course, who are still being affected with our family members over in India, the UK, and all around the world. So, one of the things that came up, in addition to the COVID pandemic, with the terrible situations with the heart, the breathing, um, organ systems, the brain also took a major hit as far as what COVID did, not only with stroke really showing up as a main problem for COVID, but now what we're dealing with is cognitive changes that are coming post COVID. So, cognition, as we know it, is now coming into the forefront. We're talking a lot more about it. We're talking a lot more about brain fog. But when we think about older adults, we tend to think of it more in terms of could this be a beginning of a dementia, an ongoing problem, and what we say a neurodegenerative problem. And that's something that I'm going to focus on today. So before we open up for a conversation, I wanted to really frame our talk um, based on a few slides. Not a whole lot of slides, but just a few, simply because we need to kind of get everyone around the same table when I think about talking to you all about what does it mean when I say memory issues? What does it mean when I say somebody's having trouble or it's a dementia? So I'm going to start it off right now with some basic facts, okay? In the US facts. In 2015, data from 2015, there were approximately 700,000 people in the US age 65 and older, okay, who died with Alzheimer's disease, okay? And 2/3 of those persons who died were women. In 2015, the total number of people with Alzheimer's disease living was about 5.1 million. Now the number is up to about 6.1 million. That's the most recent statistics from 2021. Women continue to be affected by Alzheimer's disease more than men. And we know that from a race ethnicity standpoint, older African Americans and Hispanics are more likely than whites to have Alzheimer's disease and other dementias. What we are still trying to understand is what are the rates with Asians, and I say Asians inclusive, all Asians, but specifically South Asian rates. We're trying to determine what those rates may be. And we don't have that data yet, simply because we haven't, number one, formally started looking at that data. Members of our population in the US are just coming into older adulthood ages. Yes, we have many members of our community that are 75 and 80 years old, but we were still for many years a relatively young community. Now we're entering the ages of 65 and older, so we're really looking hard at trying to get these dementia rates so we would have some numbers. So hopefully the next time I speak to you, I will have numbers for you on dementia rates, et cetera, what we can see here in the US. Having said that, because our community is global, we are also very interested in what the rates are in India, what the rates are in the UK, what the rates are in Canada, what the rates are in places where, you know, we as a community and our family members have settled in large numbers. Now, I always show this slide to put things a little bit in perspective where we are with this Alzheimer's disease dementia. Death rates due to Alzheimer's have increased 71% from 2000 to 2013. But take a look about the death rates from heart disease and other diseases. They have decreased in that same period of time. And I want you to think about possibly what that means. To me, it means that more and more people are living with chronic diseases, okay? And therefore they're not dying from the disease. And I think heart disease is one of those really diseases that you can see this occurring. People are having heart attacks or they have heart failure, but they're living with those conditions. Same thing with cancer treatments. Alzheimer's, however, doesn't fare that well. For the longest time, if you have Alzheimer's disease, there was very minimal medications in the sense of disease-modifying meds that you could use. And basically, it basically took its toll on a patient, and patients then died. Now, the term dementia is used all the time. It's an umbrella term. It's used to describe a range of conditions, and it really is associated with cognition and impairment first, and then decline. So the decline can be memory decline, the decline can be functional decline, movement. But this is the key point, and this is very important for our community. There are different types of dementia. You hear about Alzheimer's dementia most often, but there are different types, and you can see I've listed them below. In our community, we feel, and the researchers and clinicians, this pattern of a mixed dementia, Alzheimer's with vascular dementia, is really most likely what we as a community will see much more of than purely Alzheimer's disease. And I'll get into that, what that really means. But this is an important thing to see. It doesn't mean we don't have any of these others. It just means that when I see a patient who is of South Asian descent, I'm already thinking, based on what my knowledge is about vascular conditions and heart disease in our community, that if there is a dementia, most likely it would be an Alzheimer's and a vascular dementia or a mixed dementia. So you can see here the 10 signs of Alzheimer's. It's listed here: problems concentrating, difficulty doing tasks that you used to be able to do. That's very important. If you never did something and now you tell me that mom doesn't do these things anymore or doesn't do this, that doesn't, my first question is, did she ever do it? And if she didn't do it, then I would say let's move on to the next item. Changes in mood are quite important. This is where Pramila and I have spoken quite a bit. Mood and depression is very important here. And we do see these changes in mood as something to think about possibly as a dementia coming on. Personality, confusion, etc. So let's take a look at some risk factors. Now, I really boiled down these risk factors to what's in the research right now, okay? A lot of this risk factor data is coming from large community and population-based studies. This is important. These are epidemiology studies. These are studies that I work in. These are studies that my colleagues work in. So we want large numbers of people. We want to follow them over time, and we want to see whether any of these risk factors either increase your risk or decrease your risk. There is also sex differences noted here, and you see these stars. These mean that these stars and these risk factors, the effect is stronger in women. So if you have heart disease in women has a stronger risk factor for you developing cognitive decline than heart disease in men, okay? Diabetes, same thing. Cerebrovascular or stroke, same thing. You also can notice here depression. Depression, it's a strong effect in women. We know that there are differences. If depressive symptoms in women and its impact on cognitive decline is stronger in women compared to men. Now, if you look at protective factors, you can see here diet, social activities, physical activities. These are all protective for us. Cognitive activities, how well you use your brain, years of education, how long were you formally educated, how many years of schooling did you get? These things are all protective factors, okay? And then genes, you can see, are listed, but they're not the #1 risk factor for developing Alzheimer's, okay? And that's an important piece. I get asked this quite a bit. The genes are working with the environment. This is an important point. Apolipoprotein E at the bottom here. This is a gene that we all have one form of it, okay? However, it's also being influenced by the environment. We do know that if you have two E4 genes, and as a woman, you are at a higher risk of developing Alzheimer's than men. Now, if we think about the heart-brain connection, and this is where I work quite a bit, I work with cardiology, I work with the Heart Center for Women, Dr. Vogman, who's the medical director, and myself. We're very interested in how the heart functioning affects brain functioning through thinking, okay? Heart conditions in themselves, we know people complain of change in thinking. We know that it's coming from the condition. Sometimes people complain because it's the medication. They feel the medication is causing changes, the statin is causing changes. We also know that some of the heart risk factors, cardiovascular risk factors, are causing changes in thinking. This is a very big area of research, and this is a very big area for us as a South Asian community to understand this, that this can lead to our cognitive changes and decline. And so it's really important for us to take our heart health very seriously. And do everything we can to optimize our heart health and paying attention to our diet, exercise, and taking the medications. Now, the other thing that I want to bring up here is that the effects of heart disease and Alzheimer's on women, I basically put them here side by side. Take a note of this. As women mature past 65, they're almost twice as likely to develop Alzheimer's disease. Okay, that's what we know. But also know that with heart disease in women, as they get older start to have an increased risk of heart disease, often at the age of 65. That's an important piece. The other thing that's important here is that heart disease is a cause of 1 out of every 3 deaths in the US, okay? And women are being affected quite strongly compared to men. And Alzheimer's disease is 2/3 affecting women compared to men. And the last thing here is both heart disease and Alzheimer's are less likely to be recognized in women due to caregiving roles that women fill. So if we think about prevention, what is the goal for prevention of basically brain health? It's really maintenance and improvement of cognitive performance, make decisions, remain independent, and try to avoid any disability. Here are the risk factors right now, and these are what we can see. Take a look at the arrows going up, means an increased risk of having changes in thinking, and the arrows going down means you decrease your risk. And you can see when you look at the down arrows, these are the things that we all can take charge of. Physical activity, Mediterranean diet, cognitive training, which is, cognitive exercises, crosswords, etc. Moderate your alcohol consumption, and then being socially engaged. These are all things that we can control to reduce our risk. Likewise, we can also work on sleep, and we can also work on our cardiovascular risk factors to reduce our risk. So I'm going to end right now with just kind of a few things to think in your mind. How do you preserve your cognitive functioning? And these are the things that I often recognize and tell people to really pay attention to. I added avoid head trauma here because as we start moving around and as we start going out and about, we're getting on bicycles, we're going to be getting more physically active. Pay attention to your head. And if there is a helmet to be worn, wear it. If there's a situation that you think is not safe, don't be in it. Head trauma, even with what we call mild falls, hitting and knocking our head. They were called concussions, but now we're calling it mild TBI, traumatic brain injury. They also are negative for thinking over the years. And so we really are encouraging everyone to be especially careful avoiding head trauma. So I'm going to stop sharing my slides right now, and I'm going to hand it back to Pramila. And then I think we're going to open this up for our discussion.
Thank you so much, Dr. Agarwal. A very informative information and very surprising looking at some of the numbers. We do have several attendees, and we also got some questions by mail. But first, we just open up to the attendees if they have any questions for Dr. Agarwal before we move on to the mail questions. If anyone from the attendees have any question for Dr. Agarwal, please unmute yourself and you may ask. You can also put it in the chat if you want
Mhm.
for any of the attendees. Uh, Perhaps they are, just gathering their
Yeah.
thoughts to put in there. So the first question is, I'm going to ask in perspective of the South Asian community. A
Yeah.
lot of the parents in-laws are now, they've migrated to the US and they are living with their respective families, or they've grown up here, or they
Hmm.
have, I should say, aged here.
Yeah.
One of the questions the caregivers ask: how do we distinguish if this is a symptom of of age versus actually dementia happening? Is
Hmm.
this part of the annual checkup for the senior citizens?
Well, there's been a lot of discussion about having this as the wellness check and having the cognitive assessment done when it is coming into seeing the doctor. And typically it's a primary care doctor. Some people have a geriatrician do this. But during that visit, they often will use a test called a MOCA. It's called the Montreal Cognitive Assessment. It's very short to give, and it asks questions on basic arithmetic, remembering 5 items, drawing, all these things that we use as cognitive neurologists, as myself, that we all want to assess and see how people are doing. There's a score that you can get out of 30, and from that score, it can tell the primary doctor, you know what, everything looks good, or the score can indicate, I think there could be something to be concerned about, that the score should be a little higher. Maybe we should do a workup. Now, the issue many members of our community face is that if you have an older family member living with you, let's say from India, and you may not know the education level, and you may not know from India how everything was before they came to live with you. And I've heard this many times, that it's only when coming here and the family here is noticing changes. And yet, when asking family there, it's like, well, that wasn't happening here. So the question that we have as a community is, how much of this change is due to the change in geographic location, culture, getting used to a new way of living? And that's something that I always tell people, that at least a 6-month window before coming in for an evaluation is important. Okay. So people can get stabilized. Now, if you have older adults here, living here um, for many, many years, then I would say that an assessment done and the typical medical visit that we're doing for all older adults that we're trying to do is applicable and it makes sense to do. Pramila, I would say though, we have to pay attention a little bit to language. And this is a big issue that we always have. We're having it in our Hispanic community. How are we testing? Are we testing in English? Are we testing in Spanish? Are we testing here in English? Are we testing in Hindi? Are we testing in Punjabi? What are we testing? And I think this is a really fair question. And it's a fair question that family members should ask. If we're going to do a memory assessment to see how well we're functioning, if the primary language is, the mother language is the one that people are comfortable speaking and using more, let's say, than English as a second language, then testing should be done in the primary language, because that is much more accurate, and that will help the physicians and everyone much more to know that this is an accurate memory test being done, instead of saying, oh, there was some cultural differences in the words, or what you're asking me that doesn't make sense, and therefore losing points, and that's not fair. So I would say, if anyone is in the situation where you have a loved one that is not, English is not the primary, or not comfortable speaking English, there still is that hesitancy. Ask the patient, which I do, how would you prefer to be tested? And they'll tell you, I'm much better in English, or they'll say, no, I want to be tested in my mother language.
Follow-up question: does trauma increase the uh, the possibility of this disease happening?
Yeah, it's a
Uh,
great question. So I have to ask you, recent trauma, or early adulthood trauma carrying through the lifespan? And you notice, everyone, I'm making a distinction. Recent trauma could be head
Recent
trauma.
trauma,
Yeah, uh-huh.
recent trauma,
Okay.
family members or a son or daughter passing away,
Yeah,
or some kind of a disease happening, paralysis, stroke, something
right.
that has disabled
Exactly.
the body. So is
Yes.
that also a cause?
Yeah. So this is a really good question. There's a lot of research to say that the amount of stress that you're under, okay, and the chronicity of that stress and how severe is that stress does take its toll on your thinking. Now, the question is, do you recover from that? Can people recover from that? Some people do, some people don't. And there's this issue or this term we use called resilience. Some people are much resilient. They've covered a lot of adversity. They've had a lot of terrible things happen, and yet they still are not having cognitive decline, as opposed to other people where things have happened that are bad and they have declined over time. And whenever we do a cognitive assessment on someone, we ask about this. Has something recent happened? And recent could be 6 months ago, a year ago. It could be even 2 years ago. Like, how recent has this death occurred? Or how recent has this trauma been? I'm particularly interested right now in what's the data going to come out from India per se with COVID and the trauma that people in India have seen with COVID and family members have dealt with COVID, and with the mental health considerations there. They're already talking about it. We're talking about it in the U.S. coming out from a year of being basically stopping from coming out. So I think in general, this is a big issue we're going to have to face and try to understand the impact of trauma. By the way, trauma in itself impacts short-term memory quite a bit. And if it's chronic, it will stay into even long-term memories being affected. But short-term memory, focusing, it looks like depression, those are all the things that we see with trauma.
So another follow-up question was, a lot of families have immigrated, and they've provided the service that their parents or in-laws or other senior members should also come over to the US. Uh, in US, it's very common for senior citizens to move into a senior home because of other concerns, or it's all part of the life here. It's a different culture. But people coming in from South Asian countries, India, Pakistan, Sri Lanka, Nepal, even Afghanistan, and other Middle East countries also, that culture is not very prevalent there, that people can move into a senior home. Uh, what are thoughts that if there's someone who has a severe disease with symptoms which is not manageable at home, that they be moved to a facility which can take care of them in a better way?
Yeah, that's a tough one because again, you said it right off, the cultural, it's the cultural considerations and also frankly the cultural stigma of doing this, placing a loved one into a senior facility, not taking care of whether it be an older parent at home and how the community reacts to that. I think everyone on this call knows that, some people are in the community would say this is what has to happen. Other people in the community would say that's not appropriate. That shouldn't have happened. The bottom line is, and what I've said to my patients, irrespective of their, ethnicity and race, there comes a point where care cannot be given. And it's very different for everybody. It's very different for different families. But when the care can't be given to an older adult or, a loved one. And what I mean by that, it's not just preparing meals and having food there. It means dressing, bathing, not being isolated, including people, caring for their basic needs. When that care can't be given at home, okay, there has to then have to have a discussion of where else can we get the care or how can we supplement the care. And what I mean by that is home health can come in the house. You may be there, but home health is there as an aid to help out, okay, to help out with those daily activities of daily living. There are home health agencies now that are becoming much more specific to culturally specific and having home health workers that are from the same race ethnicity as the home health person that would be requiring care. And I think that's an important point. We know as physicians that if you are a physician and your patients are coming to you from the same background, in many cases, it makes the discussions easier. And in many cases, patients have said that they have much more trust and they will follow the guidelines from the physician. Well, when it comes to home health, the same thing comes from a loved one. A loved one may be more comfortable having someone from the same race ethnicity background in their home and helping them, okay? Um, there also then comes the point when it's too much for in-home care. I have families who are like 8-hour shifts, 3 different caregivers coming in around the clock every day. Now, that is a lot of care. And frankly, that's a lot of financial strain because that payment there is very, very different when it comes to payment of affording that kind of care. Um, it doesn't mean that the main caregiver doesn't do the job. It just means that the main caregiver, mostly the daughters and the daughter-in-laws who are going to be doing this care, they have a break so that they're able to carry on with their own families and take care of their own needs also. And then, if that becomes too expensive, then I've had family members say we have to go into an assisted living or a nursing facility. And this is where it gets a little bit difficult for our community and also other communities where which community will you have someone be placed that, number one, speaks the language of your loved one, number two, provides the food that your loved one is used to seeing and eating, and number three, has some cultural activities that are appropriate or considered appropriate for the community. We're making strides here. We're trying to get more of this occurring. But these are all barriers why people will say, I don't want to have mom or dad go into a facility like that. And I think we're moving in the direction where things are coming up now, where at least it's being discussed. There are different facilities, again, for everyone on this call. Some are pure skilled care, which means that this is something for total care, from bathing, getting everyone up in the morning, breakfast, etc. And then there are other facilities called assisted living, where you're there in the facility and you have people come in just to remind you for your medicines or have you come down to the activity room, but you're still, a semi-independent and actually strongly independent person. It's just that you have someone there overseeing you and being with you during the day versus you being alone.
Couple more follow-up questions, Dr. Agarwal. So we received 3 emails from caregivers saying we are caregivers for our respective senior members in the house, but unlike other diseases such as heart disease, diabetes, where they have some prior information as to how to take care of, is there any training provided anywhere in Chicagoland area or elsewhere to train the caregivers at home to say for a patient going through dementia or Alzheimer's, this is what you must do or this is what you must not do? Can you share any information in that regard?
Yeah, that's a really good question. And I'm glad that question came up because that has always been a really, it's a difficult thing, meaning you're put in a situation caring for dementia and I'm not going to say you don't have skills, but you haven't been trained, right? And what to do. You haven't been trained in what to expect. You don't know certain behaviors and certain things that you may see. This is part of the dementia. And it causes a lot of anxiety. We do have training programs. A lot of them now are coming online that you can go to. So the NIH website, and I will supply Pramila with a list of links to her where you can go ahead and Google these websites and at least get on the websites and start looking at them. The NIH has a lot of things about understanding what dementia is, behaviors for dementia, and also what to expect, okay? The other thing that, and so the NIH is my first go-to, the NIH, especially the National Institute on Aging. The second thing that is a go-to is if you Google the Alzheimer's Association here, Chicagoland, okay, Chicagoland Alzheimer's Association. Google them, and they have various activities now that are all being done digital. Before, it used to be many of them you had to show up in person. And one thing that did come out of COVID is it's just not possible to do that, showing up in person. And so now they've had to move everything to a digital platform. They're doing it again, and they're going to continue to do this. And I would say Google that and see where it is caring for a loved one with dementia in the home and see what programs are there for you to join. The third thing that is coming up is that we're having a lot more of these online caring for loved ones. And again, I'll send the link to Pramila coming out of India. Now, before COVID hit, in India, where we are seeing the rates of dementia and cognitive decline go up, In India, they were developing at a lot of the institutions there, but NIMHANS is the one, um, how to do online caregiving, meaning getting trained to do this online. You could do it at midnight when everybody's in bed, but you can learn some of the basic things to do for caregiving. And that's the third resource right now, what to do. And then the last thing is just talking about it. And I think this is something from our community that we have to start talking about this, talking about it more openly, talking about it in our social events, that we don't have this information, we're struggling, we need this information. Because if it's not talked about, the perception is it's not there. And the perception is it's not a problem. And that means resources don't come your way. Or that means no one shares resources because nobody realized it was a problem. It's a vicious circle. And I'm encouraging everyone to talk about it. I talk about it with my medical students. I've had a student, I believe Sonia is on the call today. Sonia, she's a medical student. We talked about this. What do we see with aging and dementia? What are the things that are some of the signs and risk factors? What are some of the signs and symptoms? How do you support your parents who are caring for their mother and your grandmother with that? Everything has to be talked about, and then that will bring in the resources.
With longevity increasing and the quality of life getting better, especially people are living much longer. We had an email from a female, herself 75 years old, taking care of her 95-year-old mother suffering from the same. And she said, can you please ask in your session if there is a support group for caregivers? Because again,
Yeah,
with everything increasing,
absolutely.
how long is she going to be able
Well,
to?
this is it. This is the thing, and this is a really important thing. And let's talk about this. You have an older caregiver in the 70s taking care of an older, her mother. Now, yes, she may be a healthy 70-year-old, but the stamina, okay, let's talk about the stamina for her to do what she needs to do is not as if, frankly, she was 50 doing this. And I think we have to understand that as this longevity increases, you as the caregiver, you may have the knowledge to do the basic things, but the stamina may not be there. And that's something these caregiving support groups talk about, how to manage the stress and how to manage the energy that's needed to caregive. So there are caregiving groups out there to talk about managing caregiving and how to do this. And again, those groups, if you try the local Alzheimer's Association website, you can see when those groups are meeting. I'm going to tell you, again, they're being very cautious doing the face-to-face meetings. They're still doing it online, but they definitely would be like a Zoom type of course. The other thing you can always do is reach out to us at the Rush Alzheimer's Disease Center. And if you reach out to us, our social worker, Susan Frick, can assist you in getting you close to where caregiving resources are in the community to assist with how to take care of a loved one. Okay. And I think those are the reach outs that should happen. Okay. Susan from our Alzheimer's Center will have a list of all the other events that are going on around the city and the suburbs on where to get that information and how to caregive.
Many a times we also get calls, well, you are doing, there's an Alzheimer's session going on. I don't need it. I'm 40 years old. It's way past for me. I don't need to know that. But as you said, information is something which can help prevent this to happen to us and also for our family members. Uh, you also mentioned some of the prevention tips in terms of good food, nutrition, social activities, and so on and so
Yeah.
forth. Now this can only happen if the person who we know is close to us. Is there anything else that we can do on a long-term basis? For example, if a person is 40, 50, 60 years old,
Mm-hmm.
what can she or he do to avoid this,
Mm-hmm.
minimize this, or push the disease further?
Okay, so everything that I showed you about heart health, physical activity, diet, getting good amount of sleep, no smoking, okay, all those things should be starting not just even at 40 or 30. It's a lifestyle thing. All those things I mentioned are lifestyle behavior modifications, which means that the earlier you start, the better. And as you get into your 40s and 50s, especially, taking it very, very seriously. We're seeing from the research that midlife risk factors are very important for delaying and slowing down any cognitive or thinking changes that may occur later life, 65 and older. Okay. And so paying attention to these things now is what you should be doing. Not so much saying, well, that Alzheimer's starts at 65, 67, 68. I'm 45. I shouldn't be worrying about it. I'm not worried about that per se. I'm worried about the heart disease and the other risk factors that start to increase in the midlife that are bad for you, okay, for your overall health, but are also bad for your brain health. That's what I'm worried about. And if we don't start messaging that what you do now is going to affect how you are later, then this whole idea of prevention is not getting through to our community. In particular, our community, we have to play that role to say, no, those choices you're making now are even more important for you because those are risk factors you can control. To a large extent, you can control those risk factors, and you have to work on that.
Two private chat messages. You mentioned dementia is the overall, name for this kind of problem. But what is the basic difference between dementia and Alzheimer's? And there's one more another
Yeah.
message.
And it's a great question. I knew it was coming because it comes every single talk. So here's the difference. Dementia is it's like the book. You're taking a book off of a bookshelf, and the title of the book on the back of the book says dementia. Okay. And it means how you think, your memory, your language usage, your judgment, everything. I open up the book and I look at chapter 1. Chapter 1 is Alzheimer's dementia. Chapter 2 is Lewy body dementia. Chapter 3 is frontotemporal dementia. Chapter 4 is mixed dementia. So think of it that way first, okay? Dementia is the big picture word. When you say dementia to me, it means something very specific. It means that the patient, in this case, would have changes in thinking, and those changes in thinking, whether it be calculations, memory, learning how to doing a certain task, that there are changes that have occurred over time, more than 6 months. It's been a problem over more than 6 months. It appears to be getting worse, and it is a condition that is not being driven by a bad medicine or a medicine issue, or that the person has cancer and there's going through chemotherapy, and this is why it's causing it. So dementia is something that I am ruling things out that could be causing this problem, but when it comes back and everything looks normal in the blood work and the brain, but they're still having this problem thinking, I would say that looks like it's a dementia. Now, the question is, all right, well, remember the book. That's a pretty big book. What kind of dementia are we dealing with? Well, Alzheimer's dementia has a very characteristic way of starting. And the way it starts is it starts with short-term memory loss, not long-term, short-term, meaning did you take your medicine today? Where did you put your keys? Are we going out tonight or are we going out Friday? Long-term memories are when you got married, which city you lived in when you first got married, when you went to school, who was in your class when you were in high school, things like that. Those are long-term memories. Short-term memory is what affects Alzheimer's patients. They can't remember day to day or even sometimes minute to minute. So when you tell them something, they will say, okay, I understand. And then 5 minutes later, it's completely gone. And you say, I just mentioned this to you and it's just not there. It didn't stay. It didn't, as we say, stick. So Alzheimer's dementia has a very characteristic way of starting. It's short-term memory. It starts very slowly over time. People don't notice it, really, because everybody's getting older and everybody has this senior moment. But then over time, it's not just short-term memory for little things. Then it's like forgetting to turn off the stove. Um, forgetting, and my patients forgetting how to, roll rotis if you've done them your whole life, and now you've forgotten how to roll a roti, a chapati. You don't know how to make that anymore. Forgetting especially cooking, especially with a lot of women who are cooking, now they're forgetting how to cook. Forgetting how to manage the money. Now it's getting more than short-term memory. That's what we see happening over time, and it can go on for very slowly over 10 years. That's how slow Alzheimer's can be, okay? And that's when people start to notice it, when things like the cooking is changing, driving, getting lost while driving, can't make change. If you give money out, don't know how much money to get back. Sometimes forgetting who people are, and you're like, you forgot who this person is. This person has been so close to you and you don't know who this person is. That's when people notice. And that's when they come in, they'll say to me, we just noticed this last week, or we just noticed this last year. And they're like, what happened? And my thing is, it's been going on slowly and slowly, and it just now hit a tipping point for you to notice that this is how Alzheimer's presents.
Great responses to all of these questions. We have one last question which came in by mail. This is from another caregiver. And the question was, normally we associate stress or depression with long-term memories. Something happened which has caused that stress to happen or the depression to continue. If this person is a caregiver to another senior person in the house, and the question is, this person has lost most of the long-term memories, but the person appears to be in a state of depression as what visibly is available. Does anyone with long-term memory loss or even short-term memory loss also should be relieved of the depression, or are these two different things altogether?
Yeah, it's a good question. So a lot of times when things start, before this long-term memory loss, very early on, let's say in Alzheimer's, there is a change in mood. So people become more quiet. They look a little bit more sad sometimes. They maybe get more irritable, but there's a change in mood, okay? And in those cases, it's really important that if it is a depression and there's medication being prescribed, to take it, because the medication prescribed can really make people rise up to the occasion and actually think better, okay? So that's the first thing. Not treating a depression is bad. Not treating a depression and saying, I'm not going to take the medicine, is not going to make it go away. If anything, it causes worsening of the thinking. And if you give the medicine and the thinking gets better and clears up, then, it doesn't look like we're dealing with the dementia. Now, in this case, what you're saying, where we have old memories are gone and the person looks depressed, okay? A lot of physicians would say is, if that depression isn't treated with a medicine, then it could make the long-term memory and even worse than what it is. So that means the person may not want to do anything, may not want to try to do any kind of self-care that they can, or help somebody out who's giving them self-care. So that would have to be evaluated by a doctor. What would a medication do? How could the medication help? And those are the questions that the caregiver should ask the doctor.
We will be sharing this information to this particular caregiver. That concludes all the questions which came in by mail. And again, once again, to all attendees, if there's any questions, feel free to add it to the chat or ask Dr. Aggarwal directly. And we thank Sonia and Shri for sharing a lot of the additional information, which we'll again share it on our website.
All right, thank you. I mean, this is again, it's the starting of a discussion, right? Exactly. We have to start this communication and talking. And for all the people that were asking questions and sharing, thank you. It's not easy to share. It's not easy to come forward and say, I don't know what to do. And it's certainly not easy to say, am I doing right? That's the concern every caregiver has. Am I doing right? Is there anything else I should be doing? And what else can I do to make me doing my job better? But I have to say to our caregivers, no different than what I say to our other caregivers, If you don't take care of yourself, you cannot take care of the loved one. And it's so important that you realize that. If you can't take care of yourself, give yourself the rest, talk to the rest of the family to say, I need assistance and help here. And if the family's not able to do it, trying to find those resources, it's all going to hurt in you taking care of your loved one. And that's just making it a vicious cycle, and it's just not good. So the openness and talking about this is hugely important. So we start the dialoguing, and people in our community start to hear that this is happening, and that if it were to happen, frankly, to them, they know that they can talk about it, and that is something that is an open discussion with, again, a few key people, but it's open and it's not being hidden.
Thanks a lot, Dr. Agarwal. Very, very valuable information. And as you said, not very often we talk about this, which is so much prevalent. Uh, once again, if there's any questions from the attendees, feel free to unmute yourself and ask Dr. Agarwal, or you can also send by email, and that can be shared with Dr. Agarwal. And Dr. Agarwal, as a final note, you did say there are some resources that can be shared to our audiences.
Mm-hmm. Right. So what we'll do is, I'll go ahead and get the actual links to you, and we'll get those resources to you. I have a student on, Agnes. She's also been collating a lot of resources as it relates to, the National Institute on Aging, on brain health and heart health. And we'll get all that together and we'll send it off to you. And then feel free to share with the community these resources. I can tell you, and I'm happy to say, more are coming. More are coming because the rates now are increasing. And with COVID, many people were living at home with an older adult, and we're seeing changes that they may not have seen before because they were not seeing them as regularly, and then they saw them living at home. Okay?
Thanks once again, and thank you to all attendees to spend their Sunday afternoon with this very invaluable lesson. We will be sharing all of these resources by email and also on our website once we have received it from Dr. Agarwal. Thank you, Dr. Agarwal, and always, we value the support of you and Rush Hospital. Thanks again.